Accreditation is global now. In-country accreditation is very effective. The patient experience has developed over time. Part of understanding quality and safety is very much connected to what the patient experiences.
Hi, everyone. My name is Kumar Dharmarajan. I am a co-founder and chief medical officer of World Class Health. Very excited today to be joined by Professor Sharon Kleefield. She is faculty at Harvard Medical School, as well as the All India Institute of Medical Sciences in New Delhi. She's also editor-in-chief of the Journal of Healthcare Management Standards, and just generally a global expert in healthcare quality. Really happy to have you today, Sharon. Thanks for joining.
Thank you, Dr. Kumar.
Let's start by asking you and having you tell the audience, what drew you to the field of international healthcare quality?
Okay, well, it's a long story, but a very exciting story in terms of my move from medical ethics, which is what my PhD was about, to merging some of the concepts in medical ethics to healthcare quality and safety. And I felt that there was a direct connection. And also the history of quality in healthcare was beginning with the two landmark studies that came out in around the year 2000, which actually, I think the name was To Err is Human. And the importance of that study was the first venture into quality in healthcare that became a public health issue. It was before that, we knew there were issues, but nobody really studied it. So this was the development of the medical practice study that occurred in the hospital where I worked in Boston. And so I was asked to essentially get involved in taking what we learned from those studies and to apply it directly to healthcare systems, and in particular, one of the major Harvard teaching hospitals in Boston. So that is really where my career started. And I was at the hospital for almost 10 years, working with clinicians and looking at sort of total systems approach in the delivery of healthcare within the hospital.
And then how did you get there from Boston? We share some common experiences there because I trained at a number of the Boston hospitals, and they're amazing. How did you get from there to overseas and thinking about healthcare quality, whether it's healthcare ethics related to quality? What took you from the US to places abroad?
The business of healthcare, particularly in Boston, was undergoing major changes so that some of the larger, especially the healthcare systems within Harvard, were beginning to merge. Why were they merging? They were merging because of the high costs in providing care, the redundancies in providing care, and just out of interest, the dean of the Harvard Business School started making deals with some of the big hospitals, one of which I was working, to merge their services, reduce costs. And it was at that point that I was presented with an opportunity to move essentially across the street to Harvard Medical School. and assume a faculty position that was specifically targeted at queries that came to the medical school from different countries, different healthcare systems, and there was no mechanism for Harvard Medical School to respond. And so this was the beginning of an organized approach to taking the mission of Harvard Medical School to other countries, and to respond to requests to work together. So fast forward, uh, I moved to Harvard Medical School and worked with a small group, which then developed quite rapidly, to respond to these inquiries. And as a result, I spent the next 12 years traveling to, I calculated across 5 continents and 12 countries, not as a sort of a lecturer or a consultant, but to develop long-term relationships with specific healthcare systems that wanted to develop their quality systems. And so I designed what I thought was a model that was consistent with scientific evidence, but also was culturally sensitive, which is a challenge, but very important to understand the cultures that you move into, and not to apply what we do at Harvard Medical School, but to understand the local culture, the local leadership, and the local resources, and work with them to develop their quality and safety systems.
Sharon, we've got to get you to a hospital in Antarctica, and then you can add one to your list. I mean, that's incredible. So when you speak about the importance of local culture, tradition, differences in how health systems work, expectations, you really know what you're talking about because you've been there and seen that. So as you worked with these hospitals around the world, and there's many, really curious, how did you think about those that were truly excellent at what they do? You know, in the US, we're using this term increasingly centers of excellence. Businesses are using it, health systems and hospitals are using it, patients are now more and more familiar with that term. How do you think about that high quality hospital or health system, that center of excellence in an international context?
To approach it from a simple comment, there's, of course, a lot of variation across continents, across countries, across systems. So my approach was to take a hospital in a country and to understand their total systems, their delivery systems, and the flow of patients who come through those hospitals. So I tried to go in with sort of a blank slate because it's important to understand the culture of healthcare delivery from country to country. And I think in terms of, I'll move to the world-class health approach to centers of excellence. There were and continue to be those hospitals that understand what continuous improvement in patient care, and in particular quality and safety, where many of these places are just developing and trying to understand best practices outside of their own system and to apply them. So my role was to work with them to say, look, this is what I've learned. This is what is evidence-based in terms of designing your systems. what are the metrics, and then the hospitals that were moving toward establishing themselves as a center of excellence are those places that put into place the leadership, the employees, the patients, and the cohesive of that message across the organization and metrics. So that's the evidence-based piece as well. So I would say over time, let's move from year one to my 10 years of experience. There are hospitals across countries that are doing continuous improvement, not only for the hospital systems, but also for their patients. And as you probably know with your experience, that quality and safety is a continuous effort. And so you build from the bottom up, but you also build from top down. And sort of it's that cohesion that constitutes what I have observed as centers of excellence, be it in the developed countries, be it in the underdeveloped countries. It's really the understanding, the motivation, and the standards that they put into place that leads them to say they are a center of excellence.
That's very interesting and very helpful. To paraphrase back, uh, you're speaking about the importance of continuous quality improvement at an institution level, right? At a hospital level, at a system level, with the right commitment to uh, identifying data, collecting it, leveraging it, putting it into an improvement process.
Right.
Improvement being part of the culture. And I think that's really important because when I think of quality, I think there's institutional attributes like you're talking about. And then for some things, there may be physician level components to it. For example, if I was going to have an orthopedic procedure, for this audience, I'm a physician, uh, I wouldn't go to someone who's done very few of those procedures, right? I would want to go a place where the physician has performed many such procedures. And so when she or he operates on me, there won't be anything new for that physician. Right? He or she will have seen this many, many times. But I think it's great. Do you agree that there's a clinician component to quality as well as an institutional component? And when they come together, there's real opportunity there?
That's a key point that you raise. In other words, it's the integration of the management systems and the clinical systems that come together that lead to centers of excellence. We have learned a lot over the last several years, both in the US but also internationally, with respect to the ability to measure processes, that we've learned how to manage infections better. We have looked at surgical outcomes and the use of surgical checklists. We have protocols, again, internationally, for central line insertions, mechanical ventilation, and also guidelines for the appropriateness of the use of antibiotics pre and post surgery, and also other teamwork to approach emergencies and response teams, for example. So what I'm saying is that the measurement approach is always a combination of leadership and management and making that commitment evident while bringing in the clinical side, where we have seen, I would say, dramatic improvements since the original To Err Is Human. And so the centers of excellence understand those measurement processes. And also there's an outcomes measurement piece, which again has developed over several years. And those outcomes, as you mentioned, would you go to an orthopedic surgeon that maybe has only done a few knee replacements? So the question is, where are we in terms of better outcome measures? And again, not only in the US, but across several countries where I've done work with them. And so the outcomes are what I see as the result of the patient's interaction with the healthcare professionals in that system or in that hospital. And they're multidimensional. Okay, so that means we look at unexpected mortality. We look at complications of various interventions. We look at length of stay for specific diagnoses. So centers of excellence will have the ability to look at specific diagnoses, specific procedures, to see if they're effective, to see if they're safe. We look at the number of surgical procedures. And as you mentioned, I look very carefully at the system of privileging. In other words, to make sure that the right physicians are trained to do specific procedures and what their volume is and their specific outcomes. We look at readmission rates. Okay, that gives you a window of patient outcomes. And so, if a readmission rate is a little higher than what we expect globally, we have to look carefully as to who those patients are, why they're readmitted, and if they're readmitted for the same procedure or diagnosis that they were originally treated for. And then we look at things like unplanned return to the emergency room, to the ICU. Again, these are all outcome measures that reflect both the management and the clinical systems.
So what I'm hearing from you, Sharon, in terms of the management systems, the clinical systems, the commitment to collecting data, measuring some of these key multidimensional attributes, using that to drive continuous quality improvement, that can happen in the United States, in high quality institutions. And those are not things that are prohibited from happening outside of the country. Those are things that in many cases can be enabled all around the world. So do you agree with the idea that international centers of excellence and domestic centers of excellence, here domestic being United States, but any country, they share a number of attributes, and that these attributes can exist all over the world as long as they're present within that hospital system?
That is absolutely the point. That we're now looking at global quality. That's what we're looking at if we hope to identify, nurture, and measure centers of excellence. So again, it's the global piece that world-class health is developing in their centers of excellence definition. That's what I think. And so there's a global marketplace where we share experiences, metrics, and I will say one word about accreditation, because accreditation is global now. And there are various ways to use accreditation. I see it as sort of the floor for quality. There are hundreds of Joint Commission accreditations and also we're seeing local accreditation systems. In other words, the country itself develops their own accreditation standards, typically are reviewed by ISQA, which the International Society for Quality in Healthcare, because you can't just become an accreditor on your own. There has to be some standards followed. So, accreditation, I think, over the last several years has become uh, global. And there are many systems that are available, Joint Commission being one of them. But again, in country accreditation um, is very effective. There's the NABH in India. Thailand has their own accreditation systems. And these are people who may work with a joint commission or other established accreditors to learn and to fashion their standards that are global, but also culturally specific. And I would say that that's an important factor that would be included in the centers of excellence.
How do you think about the patient experience as part of this in terms of a center of excellence? So, a number of the metrics you talk about are extremely important. Mention things that are akin to complication rates and unexpected events that happen to patients. Nobody likes that to happen. But then there's the actual experience of being a patient, right, in a hospital setting, whether it's receiving procedure, whether it's receiving medical treatment, cancer treatment. How do you think about the patient experience side of a center of excellence? And maybe this is a good opportunity to talk a little bit about patient-reported outcomes. We've spoken about ICHOM and a number of other bodies that are interested in this, but talk to me about what it feels like to be a patient and how that there's really a quality side to that as well, beyond the quote-unquote technical side of doing a procedure.
Right. Very important. And that the patient experience has developed over time. In other words, understanding and making sure that you understand what patients experience when they enter your organization, your hospital. And we haven't had a lot of international data, but it's beginning, because part of understanding quality and safety is very much connected to what the patient experiences. And there are, you mentioned ICHOM. Now, ICHOM is an organization that is global. It started at the Harvard Business School with some funding, but is definitely a global organization that seeks to define and implement what we call PROMs, patient-reported outcome measures. And these are beginning. I would say this is kind of a new methodology, to the point where they're looking to accredit organizations that apply their order sets across many, many diagnoses. So, for example, a woman who goes through breast surgery and follow up for breast cancer, that's one that's been in play for quite a while, both here at the Harvard hospitals, but also internationally. And so it's important to really understand and measure how the patient feels and reacts to their interactions with the healthcare system, be it admitting, be it nursing. All of those who focus their care on the patient and a multiple of patients within this diagnosis. And so that is very new. And I would say it's not really become standard either in the US and internationally. Although there are companies like Press Ganey, for example, that focus on patient satisfaction. And most, if not all, of the hospitals within the Harvard system, but also across the US, use Press Ganey. And the benefit of that is to compare yourself. So if you look at the top 100 hospitals in the US with respect to patient experience, you can gain a lot, because I would say those experiences, especially for those centers of excellence, have a very high rating for the patient interacting with a multiple of people and a multiple of systems. So I would say that's an area that should be a part of centers of excellence anywhere,
I'd
because it's
agree.
not difficult to measure. I would say the key is to use those, shall we say, measurement systems for patient satisfaction that are comparable, whether or not it's a developed country, an underdeveloped country. These are all extremely relevant to quality and improvement of care. So it's an important factor.
That's great. I'd agree with you. What I'm hearing is that, especially in an international setting, patient-reported outcomes are relatively new. I think they're relatively new in the United States
Right.
as well, but especially so internationally. They're a key part of that experience. I mean, it can be very disconcerting being a patient, very confusing. So many things are changing. It's obviously a stressful environment in many cases when you're in a hospital and you're sick and you're feeling well. And I think there's a real opportunity personally to have great experiences actually be part of the healing process.
Right.
Being a patient in a hospital and you're stressed and you're not able to sleep and everything's
And it's
changing.
noisy
It's
and
noisy and you're in a shared room and the patient next to you is sick, which is also disconcerting and stressful. I think there's a lot for us, a lot of opportunity here to have strong patient experiences actually support healing. Because if we're sick, one of the things we're supposed to do is take rest, right? And we've all been in times where we didn't take rest and maybe we got sicker, and times where we did take a rest and recovered sooner. And I think that's just an opportunity in the US as well as internationally. All right, I want to be extremely respectful of your time. So I have one other question. So when you think about the global patient, right, patients around the world, what do you think they're looking for, and how do you think global centers of excellence need to position themselves and think about the care they deliver to attract these patients from around the world coming to them?
very important question. Um, the global patient has common characteristics, I would say. They want to be assured that whatever diagnosis or procedure will be safe. And they want to know that in terms of maybe data or certainly interaction with the individuals who will be providing that care. They want to be assured that their stay, if it's in a hospital, that the hospital is safe. In other words, that they won't fall, that the medications will be accurately prescribed. So they want to feel confident that on their own level, they will feel that the care provided by a number of providers is sensitive to themselves, their needs, and I would say their local cultural expectations. And I'll give you an example that always sticks in my mind. When I was beginning to work in India, and I was working in a large hospital, I looked at the use of pain medication for patients post-surgery. And there was a little locked box on the unit, and there were very few medications in there. And sort of coming from the West, I said, these are all the pain medications that you use? Oh, yes, that our patients understand that. And they're comfortable with it. What I'm saying is that if there's a global patient, let's say, and a patient goes to a hospital in Asia, in Europe, wherever, it's important to communicate with the patient in terms of their expectations and what the local culture typically provides. And so that, to me, is a ticket to satisfaction. That communication, that understanding for the patient from day one to admission to day 3, day 4, whatever the expected stay is, for them to see exactly what they are to expect and to be able to communicate if those expectations are made, perhaps missed. And so there's a joint effort between the patient and the team, and it's ongoing. And I published an earlier study on the use of critical pathways in a large Harvard teaching hospital where I was working. And this was before Epic. This was before more digitized record keeping. It was really done in the chart. And so it was a clinical pathway for various surgical procedures, let's say, but they were across many procedures, where the staff communicated that pathway to the patient it was actually pre-admission, so the patient knew what they were to expect at every day of their stay. When did they get out of bed? When could they walk comfortably? When could they eat? And so this promoted patient satisfaction to a level that I could actually publish. And I had a database at that time was about 50,000 patients. And so it was quite provocative, let's put it that way. And of course, things have changed and there's digital approaches now. But nevertheless, the key functions of that interaction are very important, and they're cross-cultural. In other words, they can be across several continents if we understand what those key interactions look like.
That's really heartening because at the end of the day, first off, I want to see that paper. Please send it to me. That sounds amazing. Would love to read it. Is that we're human at the end of the day. And what I heard, you said a lot more than this, but distilling it down is patients want to feel safe. They want to feel cared for. They want to feel listened to and understand what's happening as part of really strong communication. And they want to be comfortable with that. And at the end of the day, I think healthcare is a space where there's a lot of opportunity in all of those areas to help give patients more of all of that so that they have a better experience interacting. Because, as a physician, sometimes I take it for granted because I see patients all day. But when patients come to see me, especially if I'm seeing them in a hospital setting, it's often because they're sick or they're there for a procedure, something out of the norm. And I can very much understand that in that setting of higher stress, higher uncertainty, those very basic things we crave as humans become even more important. And I think there's so much opportunity to do good there for patients. And I'm really glad to have learned from your insights. Our audience is going to learn from your insights. That makes someone like you, especially important here to understand your perspectives. And we're really glad we were able to spend time together today. And I'm
Yes.
sure that now that we've gotten you started, we'll bring you back on in a bit to hear more of your stories. And super glad that you were able to spend time with us today.